So just as a recap this morning, you've heard several lectures that I've given. One was just on fat grafting philosophy and technique. The second one that I gave was on fat grafting versus fillers, and the third one I gave was on fillers. This one is going to be on fat grafting versus implants. Just more a philosophical construct and how to pick your treatments. I do believe in implants, but I believe their role is more limited today since we have advanced soft tissue contouring that's available. Disclosures, this book, I do make about $20 to $60 a year on this. So if you do buy it, you can buy me a coffee instead. Your choice. I bring this slide up again, and I love using this slide because if you look at that, it's truly a volumetric collapse. Remember, when you look at this, there is a greater soft tissue envelope collapse than bone collapse. In fact, it almost looks like she has a cheek implant up there because there's bone exposure. Now, clearly, there are many ways to skin a cat. I'm not here to say you have to use soft tissue. You saw from Bill Viner doing some beautiful work with implants. This is not to say you cannot do that. Clearly, you can. But we need, to de-skeletonize that face, we're going to have to add the soft tissue envelope, not add more skeletonization. To repeat some of the risks with fat grafting, everything you do in terms of the procedure is not risk-free. And so fat has its risk. It is not bioinert. And I've said that word a lot of times, and I say that to my patients. It's a bioactive, metabolically active product. When you understand that, then you got to remember that if someone is heavier set and they go through a cyclical weight gain and loss, they may not be as an ideal candidate for fat. And when you decide if you're going to do a fat graft for them, for me, it's typically ideal if they are relatively stable, obviously. If they're not, if they're in the process of losing weight, you would think intuitively it would be ideal for the patient to reach an ideal weight and come and see you. Well, I don't believe that they're going to maintain that ideal weight. So for me, I like them to be about a third way down to their ideal weight and relatively either stable at that point or in progression toward greater loss, because I can always add a hyaluronic acid-based product when they're at their nadir. Because I don't believe that they're going to stay at that nadir. I believe that's going to be a point where they fluctuate back up. I use the analogy of hair transplantation, and I liken it here to the same thing with young patients. When you're dealing with very young patients and you're doing fat grafting for them, you do have a little increased risk profile because over their lifetime, there may be some changes that are favorable or unfavorable based on metabolic changes and further aging. So the younger you do a hair transplant, the higher the risk profile. And the younger the patient you work on fat, the higher the risk profile. And because there's going to be a lifetime change with a permanent filler, plus it's bioactive, metabolism does change over a lifetime. So these limitations and risks are important. I was lecturing in 2007 in Colombia in South America, and right when I finished and got off the stage, a physician says, Sam, it was a great talk, and I wish I had heard this talk because I'm using fat as a reconstructive modality. And remember, as I said 4 times earlier, it is not bioinert. And so this jaw sort of grew like a tumor. And it's important you understand that fat that can fluctuate and change when you're using it in isolated formats. So when someone comes in, they have an isolated facial defect. I do not use fat. Almost never. I don't believe I've ever used it. I use it as a beautiful contouring. So all these risks are not meant to scare you. If it's done in the right hands, with the right judgment, the risk can be very limited. And so you have to understand that. It's bioactive. It is this soft tissue contouring modality that's used, as I said earlier in my lecture, as a mattress foundation. So what is the basic premise of this entire talk? And now that we got these risk concepts out of the way, it is simply this: like replaces like. I like that statement because it helps me encapsulate the concept of what I'm trying to articulate here, which is that if you have a soft tissue deficit, like a microgenic chin, you probably need a chin implant, okay? You can't stuff that with fat. If you've got a soft tissue envelope loss, then perhaps you replace that with a soft tissue replacement. So as a slide I showed you earlier today, we lose volume. Well, what is the component of that volume if we're losing volume? Is it fat or is it hard tissue? What do we lose more of? Well, I would argue that we actually lose a larger proportion of our soft tissue envelope than our hard tissue envelope. And we really, yes, if you look at a CT scan, we definitely lose some bone tissue as we mature, but not very much in the current era of good dentition and good health. So if you now re-envision that idea, we lose our soft tissue envelope so that the difference between the soft tissue to hard tissue narrows. What happens if you put an implant in? In my opinion, if you put an implant in, you further actually narrow that gap. So you have actually more bone exposure unless you're putting a lot of bone implants in there to try to cover the bone. So let's go back to that aging model again. If there is a relative greater disproportion of soft tissue diminishment versus hard tissue, then what is the option? Well, I like to replicate that difference, which I believe is going to simulate or emulate youth. So understanding that is that when you look at youth, the soft tissue envelope is robust, and you can cover any mild bony deficiencies with soft tissue if it's mild. But I believe that the soft tissue envelope, especially the complex nature of today's fillers, as you saw this morning, I filled 20 to 30 areas of the face rather than just sticking in one area. It's very hard to do that with a hard implant. You can do that in one area, you can put it in the malar area, but then you got to put a tear trough implant, then you got to put a brow implant, then you got to put a temple implant, then you got to put a chin implant, then you got to put a buccal implant, then you got to put an extended malar complex implant. So what I'm saying is that if you understand this like replaces like concept, plus all these shadow points, I think it helps, and it helps you achieve that blink that you're trying to achieve. And remember what I was saying, that soft tissue fillers are meant to help you execute on minimizing transition zones. In my opinion, in a lot of implants, if you don't put enough implants or put them well, you're going to exacerbate facial transitions, whereas the whole point is to minimize those transitions. But as I said earlier in this talk, risk-benefit ratios are critical. They are that you have to educate a patient about those risks. And I believe an implant is fantastic in a younger patient with hypoplastic bones because, you know, there's a higher risk profile with fat transfer. Obviously, you can do HAs, you can do things that are reversible, you can understand limited permanent fillers may be safe, but aggressive ones have a little higher risk profile for the patient. But implants over time become exposed. So a lot of times what I hear from my patients is, you know, I really like that cheek implant in my 20s, but now that I'm mid-30s, I don't like it. And so what are the options? Well, you cover it, or you take it out. With fat transfers, though, there is a risk when you're much younger because there are metabolic changes over your lifetime and weight fluctuations. So that's something that I take a good history of. Not what does your mother look like, what does your father look like, what does your weight profile look like, what changes have you observed, what is your diet like, how have you fluctuated, how old are you, etc. And you take those risks and you weigh them and you counsel the patient. And you remember the good news is I don't try to shoot with fat to get toward 100%. I just try to get improvement. And if you understand that, then I believe the safety profile really is significantly enhanced because I'm not trying to shoot for perfection. So the idea that like replaces like for me is a really good way to help patients understand the philosophy, and maybe it makes sense to you as well. So in this gentleman, a chin implant and neck lipocontouring is ideal. I don't think I could have fat grafted this into position. This slide here is an easy one. I like to represent material in multiple facets to help you understand this, which is an older patient, I think fat is ideal because their soft tissue envelope is primarily absent. A younger patient or a patient with weak bone structure, an implant may be better. Fat loss with someone that has a lot of fat loss in their face because of volume loss is great, but someone having that fat loss because they just lost 200 pounds after a lap band and they just did it 2 months ago, may be better with an HA until they prove themselves with a track record that they're going to stay stable. So I always encourage everyone to think with an artistic idea, understand safety, and communicate better with patients. Thank you.